So an integrated care system will be obviously all the partners who work within a particular geography, and across the country those geographies are not all the same. In fact, some are really quite different. So the system that I work in, Gloucestershire, is one of the smallest ICSs. It's less than 1 million population. The boundary is coterminous with the CCG boundary as was, and we have a one-to-one-to-one relationship. So we have one acute hospital, that Gloucestershire Hospitals Trust, that serves our county. We have one local authority, albeit it's a two-tier local authority. We have one health and care trust, which is an integrated mental health and community trust, and our boundaries are all the same. Now, you have other integrated care systems that will cover huge geographies of kind of 4 million people, where they may be incorporating 3 or 4 CCGs that used to exist, multiple local authorities, multiple trusts. So the size and scale of different ICSs is quite different across the systems in the country. And we then have, at the top of that integrated care system, we have what's called an integrated care board, so the ICB, and that will be a partnership board from those different memberships across the system. Now, it's not a representative board, so what I mean is you don't have to have every single member organisation sitting around the table. So in Gloucestershire, we probably will have every single organisation sitting around the table, but that's a lot easier to achieve because there's 4 of them. If you are one of those really huge areas that I talked about and there's maybe 20 organisations, you obviously would struggle, not least to sort of manage and have a sensible conversation at that board. So there will be that partnership board at the top, and it isn't necessarily a representative model, but it will have a flavour of the different parts of the NHS, and you will have levels of delegation. So people will then have place, which is the name for it we're using in the NHS, which in some of those really big ICSs is going to be a similar footprint to the original CCGs, and they will then be kind of localities within the ICS. Now, in a really small one like Gloucestershire, I realize this might sound a bit confusing, but probably how place is defined in the national architecture is coterminous with our ICS. So Gloucestershire is probably a place and an ICS, whereas in, say, West Yorkshire and Harrogate, you've probably got 4 or 5 of them. And depending on the size, the resources may or may not be then delegated down to place. So you end up with ICSs being reasonably, again, different at that top level. The way I would describe it in a kind of simplistic way is that you could think of it as like a thin ICS, where what you're taking up to that ICS level is relatively minimal and you're delegating a lot down, or a thick one, where actually most of the kind of business is being done at that ICS level, and very relatively little is delegated to place. And then we also have an integrated care partnership that will sit alongside the integrated care board. And that will be another board which includes then wider partners like local authorities and so on. And that, I think, candidly, is a bit of a fudge, whereby the NHS wants a point at which it can hold itself accountable for the money. So effectively resources are delegated to the ICB. But it wants a board where it also has local authorities and others who are maybe not directly accountable. So that's why I think we've ended up with 2 bodies at the top of ICSs. And our job at the moment is just defining how we will incorporate all of the CCG statutory functions into that ICB with that new partner membership model. For people who like to talk about governance, there's a lot to think about there. And structure all of that and manage that relationship with an ICP, which then also has a relationship with the Health and Wellbeing Board. So quite a bit of complexity in the structure that we're designing and setting up at the moment. But the view is that at least all those NHS partners for a geography will be together with a shared set of objectives around managing resources in the best interest of their population.
Yeah, and it's interesting you talk about the complexity for you, whereas actually yours is quite straightforward. And I guess you go to other parts of the country and be very different. And one
Yeah.
thing I think that our audience sometimes, or all of us, I think, struggle with is how much is this a nominated or a template architecture, you slot your own bits. And I think what we're taking from what you're saying is that actually a lot of this is kind of bottom up, and you've got almost the acronyms that you need to conform to, but actually you've got to think locally about how does this work for us, and one place or three places or what have you. And then the thick or the thin, there's going to be a huge amount of variation, I guess, between the 42, isn't there?